hopefully we can have a little conversation. So you'll notice that I didn't tell you whether to use thiazide, ACE or thiazide ARB or, ARB, CCB combinations. And if you have comments or questions about that, this is the time to bring them up. So a show of hands, how many of you sort of routinely give a single pill combination to a patient who you've newly diagnosed with hypertension? Show of hands. And how many of you would never do that? Okay. So any comments? So we have some believers and some skeptics. Yes? What about the elderly population? Yeah, so the elderly population in some ways are very similar to our people that would have been in some of these studies. In other ways, they're different, and I think the concern is in the frail elderly. So when I'm talking to residents, I say, listen, you can follow the SHEP guidelines for that 80-year-old if they really are over 80 or they look like they're over 80, right? Because there are some people who may be 70 but are very frail. And the converse may be true, that if you have an 85-year-old but they look like they're 60, well then, you might be willing to be a little more aggressive in terms of blood pressure lowering. I think that if you're concerned about, so with the single pill combos that we have, generally you will get less hypokalemia, you'll get less hyponatremia, you will get less pedal edema if you use the single pill combo up front. So those would all be very good things for the elderly. The concern would be lowering blood pressure too much. And the way you get away from that is you use very low dose combo therapy. And how many pharmacists are there here? Okay, so I don't know if you guys need to plug your ears or not at this point, but most single pill combos, you can cut them in half. And the patient can be instructed to, you might check with the pharmacist first, to cut the pill in half. Start with a very low dose, the lowest dose available in a single pill combination, and then take half of it. The other thing that will do is actually reduce cost, depending on which product you're thinking about using them. Some of them are quite cheap, and in some cases there's actually cost savings associated with the combination. But that would be patient dependent. Other comments, thoughts? Yes? Yeah, good. So the comment is the BMI is elevated, it's 31. Which in my practice barely, those people look thin. But the point is well taken that there is some lifestyle measures that would be appropriate. And I would argue if this guy really is just coming in for an annual physical and hasn't been seen in 6 years, he's probably not doing any lifestyle related activities. So, I agree completely. And if this was the only visit and all I had was a clinic blood pressure measurement that was 164 over 88 or whatever it was, I wouldn't necessarily feel strongly about initiating therapy at that point. The problem is that if we know that his glycated is 8%, he's got diabetes, even if you give him some time, he will certainly be hypertensive and will almost certainly require drug therapy. And the question then becomes, when do you institute that? There are some studies that suggest that aggressive early blood pressure reduction actually is worthwhile. Study like Value, for example, where getting on top of that early makes sense. But lifestyle would obviously be an important part of the package. How many of you have heard of the Look Ahead trial? So the Look Ahead trial was looking at very aggressive lifestyle measures and compared to just regular management of patients with no instructions around what to do with drug therapy as far as I can tell. And the Look Ahead is a really interesting study because what it showed was that lifestyle intervention makes a big difference. You can actually do a lot in a year with very aggressive management. what was disappointing to some was that in terms of clinical outcomes, there wasn't much evidence that very aggressive and successful weight reduction and waist reduction and that sort of thing actually affected clinical outcomes. The reason I think that happened is that if you look at the group who were randomized to the usual standard of care, their physicians up-titrated their drug therapy more than the up-titration of drug therapy in the patients who were getting the intensive lifestyle modification. And so what I tell patients is, listen, there's this, and then outcomes were the same. So you could take more drugs and less lifestyle and have a certain number of outcomes. You could have more lifestyle and less drugs, and you'd end up with about the same outcome. So when I have patients who say to me, Doc, I hate drugs, I say, well, there's this fantastic study called Look Ahead, where patients who got less drugs did just as well, but this is the menu of activities from Look Ahead that you would need to sort of participate in. And then I have other situations where, a patient comes in and they're kind of sad and they say, well, Doc, I've tried so hard for my lifestyle and it just isn't making any difference. And I say, well, you know what? There's this great study called Look Ahead that shows that if you just take a little bit of drug therapy, we can probably, help you, even though you're not that successful with your lifestyle management. So you can use it both ways. But any other thoughts?
George, what about the argument that if you use single pill combination, and you get side effects and you don't know?
Right. Absolutely. Yeah, that's a very good question. So if the question is, you give them, I picked on ramipril hydrochlorothiazide. You give them ramipril hydrochlorothiazide. Patient comes in with a skin rash. Is it the thiazide? Is it the ACE? How do you know? Now you end up with both products on their list of allergies, and when they come in to see me, they say, "Oh, Doc, I got a terrible allergic reaction when I took that." The issue, from my perspective, is that with most side effects of the blood pressure medications that we use, the effects are obvious, and you will know which component of the fixed dose combination is causing the trouble. So we're going to do a little, so this is a patient interaction. So you start the patient on atenolol chlorthalidone, and the patient complains of fatigue. Okay, what about they complain of a really slow heart rate? They complain of muscle cramps and low potassium, chlorthalidone. They complain of low sodium, chlorthalidone. So you don't have too much trouble sorting that one out. Well, let's talk about Twinsta, calcium amlodipine with telmisartan. So you start them on that, and they complain of ankle edema. The amlodipine. They present with high potassium, telmisartan. So the argument that you can't tell if they come in with a side effect what it's going to be is only true for very rare, generally idiosyncratic reactions. With the drugs that we use, it's generally not a problem.
I'm going to ask one last question, George, because we have 2 more minutes. So
Okay.
What about these ultra low dose combinations that are coming out?
Yeah.
I don't think they're available here yet, but do you see any role for those? Or you mentioned you just have the dose, but...
Yeah, so there are some very low dose medications, and I think that again, in the elderly patient, the frail patient, where you want to start with something extremely light, I think that's where they would have a role. Again, the number of titration steps required to achieve good blood pressure control is an issue from my perspective. And if you have a guy like the case that I showed who's starting at 165 over 90, who's diabetic, starting them on the ultra low dose may be the inappropriate thing to do, because it just means that it's going to take at least one additional visit to up titrate within the same class of medications. So I think it's useful when patients are close to target or they're extremely frail and you're concerned about them, but in general it doesn't help us achieve our targets.